What's going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my cardiology playlist. In previous videos, we talked about stress cardiomyopathy, also known as Takotsubo syndrome or stress cardiomyopathy. We also talked about dilated cardiomyopathy and chemical-induced cardiomyopathy. As for today, we shall talk about hypertrophic cardiomyopathy. What does hypertrophy mean? It means increased in the cell size, not in the cell number. Is there such a thing as hyperplasia of the myocardium? The answer is no, because the myocardial cells are permanent cells. They lost their ability to divide and replicate. They can grow bigger, not more numerous. In other words, hypertrophy, not hyperplasia. This disease is characterized by asymmetrical hypertrophy of the interventricular septum, which is the septum between the right ventricle and the left ventricle. It's also known as hypertrophic obstructive cardiomyopathy. And what does cardiomyopathy mean? We have a pathology in the muscle of the heart, where the muscles are too big. Click the like button, click the subscribe button, and let's get started. Please watch the videos in this cardiology playlist in order for maximum understanding and retention. If you have watched my pathology lectures, we've said that cellular growth includes hypertrophy, hyperplasia, metaplasia, dysplasia, and neoplasia. When the cells increase in size, it's hypertrophy. When they increase in number, it's hyperplasia. Since heart myocytes cannot replicate anymore, they only undergo hypertrophy under cellular stress. Back to basics. Here's the wall of the heart. The inner layer is the endocardium, middle layer is the myocardium or the muscle layer, and then the outermost layer is the pericardium. Cardiomyopathy affects the myocardium. That's why it's called cardiomyopathy. Types of cardiomyopathy include dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, Takotsubo cardiomyopathy, and chemically induced cardiomyopathy. Many of the chemicals that cause chemically induced cardiomyopathy are the same chemicals that can lead to dilated cardiomyopathy. For instance, alcohol, cocaine, doxorubicin, etc. In dilated cardiomyopathy, the patient usually has symptoms of heart failure, so it's called congestive cardiomyopathy. In hypertrophic cardiomyopathy, it's called hypertrophic obstructive cardiomyopathy because I have obstruction of the left ventricular outflow tract. It's also known as idiopathic hypertrophic subaortic stenosis because the stenosis, the narrow part, is below the aortic valve, not in the aortic valve. So it's not aortic stenosis, it is subaortic stenosis. And the disease is also known as asymmetrical septal hypertrophy, referring to the septum between the right ventricle and the left ventricle. In the next video, we'll talk about restrictive cardiomyopathy or infiltrative cardiomyopathy. As for Takotsubo cardiomyopathy, we have talked about this in a previous video. Dilated cardiomyopathy, the heart is super duper dilated, excellent at diastole, but so bad at systole. In hypertrophic, it's the opposite. I am good at systole because I have very thick muscles, but I suck at diastole. In restrictive cardiomyopathy, I'm restricted from filling. I cannot fill, bad at diastole. And if I cannot fill, well, if there is less input, there will be less output. This right here is a normal cross-section of the heart. In hypertrophic cardiomyopathy, we look like this. I have concentric hypertrophy, not eccentric hypertrophy. Eccentric hypertrophy was the topic of the last video, which was dilated cardiomyopathy, but today it is concentric hypertrophy because the sarcomeres of the muscle have been added in parallel and not in series, so the heart grows thicker inward and the outflow tract becomes narrower, and that's why it's called left ventricular outflow tract obstruction. Look how narrow this is compared to the normal. Let's say I have systemic hypertension. This will raise the afterload. This is pressure overload. Chronically, it can lead to concentric hypertrophy. How about if I have aortic stenosis? Chronically, it can lead to concentric hypertrophy because the ventricle has to work harder to push blood against this narrow aortic valve. In concentric hypertrophy, we see S4 heart sound or S4 gallop, but in eccentric, we see S3. So let's compare between the two quickly. Eccentric hypertrophy is caused by volume overload or high preload. Concentric hypertrophy is caused by pressure overload or increased afterload. We see eccentric hypertrophy in regurgitation valvular disease such as aortic regurg, mitral regurg, etc., or dilate cardiomyopathy. In concentric hypertrophy, we see this in stenotic valvular disease, such as aortic stenosis, and in hypertrophic cardiomyopathy. This is a systolic failure, but this is a diastolic failure. This heart is bad at systole, so usually the ejection fraction is low, but this heart is usually good at contracting. If you want to download these doozy colorful handwritten notes, go to my website medicosisperfectionalis.com. I help you understand and pass exams. Let's go back to normal anatomy. Here's my left ventricle. The left ventricle could be divided into two parts. You can say that this is the main cavity and this is the left ventricular outflow tract. If you want to be more technical, this is called the rough inflowing part and this is called the smooth outflowing part. Why is this part rough? Because it has trabeculae carni as well as the papillary muscles. Why do we call it the inflowing part? Oh, because we receive blood from the left atrium, inflow. However, this part is the outflowing part because the blood is leaving the ventricle and going to the aorta. Muscular tissue here, fibrous tissue there. Why is this fibrous and not muscular? Because if this part was muscular, when I contract during systole, I'll close it because the muscles will shorten and get closer to each other and there will be no space available for the blood to leave. All of that was normal. But look what's going to happen if I have hypertrophic obstructive cardiomyopathy. Look at this, asymmetrical thickening of the interventricular septum. Oh, this will lead to obstruction of the left ventricular outflow tract, which means less blood will leave the ventricle and go to the aorta. Even though the left ventricle muscles are thick and very good at contraction, still less blood will leave the left ventricle and go to the aorta because the outflow tract is very narrow. I have asymmetrical hypertrophy of the interventricular septum. I have concentric hypertrophy of the wall of the left ventricle. I have obstruction of the left ventricular outflow tract. So eventually less blood leaves the left ventricle to go to the aorta. Cardiac output decreases. I get symptoms of decreased cardiac output such as pre-syncope, syncope, fatigue, dizziness, incoherence, etc. because there is less blood going to the brain. But also there is less blood going to the heart itself because the coronary arteries emerge from the ascending aorta. Oh, I can get angina, exercise intolerance, palpitations, etc. And there is a very important phenomenon that you have to pay attention to. The interventricular septum gets bigger and thicker, and it can grab the mitral valve closer to it. So instead of the mitral valve looking normal like this cusp will be pulled more towards the interventricular septum, leading to dilation of the ring of the mitral valve, which leads to mitral regurgitation from the left ventricle to the left atrium. So what would I hear? You would hear the murmur caused by the HOCM, which sounds very similar to the murmur of aortic stenosis, but the site is different. Both murmurs are crescendo, decrescendo, harsh systolic murmurs. However, the murmur of aortic stenosis is heard at the aortic area, A1, which is the right second intercostal space. However, the murmur of HOCM, because the obstruction is down here, will be heard on the left sternal border. So, in this patient, you can hear systolic, harsh, crescendo, decrescendo murmur at the left sternal border, and the murmur of mitral regurg, which is high-pitched pansystolic or holosystolic murmur best heard at the apex. And when it radiates towards the axilla, which is your smelly armpit. Let's review very quickly. What happened here in HOCM? I had asymmetrical hypertrophy of the interventricular septum. I have concentric hypertrophy of the left ventricular wall. It doesn't have to be both, it could be one or the other. Approximation of the interventricular septum and the mitral valve, which leads to mitral regurgitation. The low cardiac output causes angina and syncope. My heart has a problem, my brain has a problem. And anytime the septum gets thick like this, or when the ventricular muscle gets thick like this, what's going to happen? Arrhythmias. And how did that make you feel? Palpitations. Let's compare between most murmurs, let's say aortic regurgitation, mitral regurgitation, tricuspid regurgitation, mitral stenosis, tricuspid stenosis, etc., and HOCM/mitral valve prolapse. With all murmurs, if more blood is flowing by the diseased valve, I get more murmur. If less blood is flowing by the sick valve, I get less murmur. More blood, more murmur, less blood, less murmur in all murmurs except mitral valve prolapse and HOCM. Here, more blood equals less murmur, and less blood equals more murmur. Let's practice. Suppose that I am squatting. What does that do? It squeezes the veins in my legs, which raises the preload. Increases preload means increase amount of blood that goes towards the heart. More blood equals more murmur. So the intensity of all of the murmurs will go up except mitral valve prolapse and HOCM. How about a hand grip? A hand grip raises the afterload. More blood, more murmur, but not in HOCM and mitral valve prolapse. Here, more blood equals less murmur. How about raising my leg? This boosts the preload. Okay, increasing the blood, increasing the murmur. But in HOCM and mitral valve prolapse, it decreases the intensity of the murmur. How about the Valsalva maneuver like this? What did I do? I raised my intrathoracic pressure, which prevents venous return from returning back to the heart. Less blood, less murmur. But not here. Less blood equals more murmur. Next, let me stand up suddenly. What's going to happen? Blood is going to pool in my legs. Blood is accumulating in my ankles, not in my heart. So the venous return decreases. Less blood equals less murmur. But not here. Less blood equals more murmur. Now you know this. Let me explain why. More blood equals more murmur and less blood equals less murmur in most murmurs, and why the exact opposite takes place in HOCM. Think about it. Let's go back to normal physiology. Normally, the blood flow in your vessels or across your valves should be laminar flow. Can you put your stethoscope on a vessel and hear the normal laminar flow? The answer is no, unless you are a very experienced cardiologist with a robust stethoscope. But the average medical student or the average physician with the average stethoscope will not be able to hear the laminar flow.
But hey, Medicosis, I'm a first-year medical student with a very cheap stethoscope and I heard the laminar flow on a blood vessel.
And that's more likely a hallucination. This is normal. But if the laminar flow became turbulent, can we hear this? Yes, we can hear this with a stethoscope. Amazing. So if I increase the blood on a sick valve, will I hear it? Of course, because when you increase the blood, you're increasing turbulence. You will hear it more intense. And that's why more blood equals more murmur, i.e. greater intensity of that murmur. Conversely, less blood equals less turbulence, and you will hear it less. This makes perfect sense. But how come in HOCM the exact opposite takes place? Look, suppose that we brought more blood to the heart, okay? Hey, left ventricle, we're giving you more blood now. What does that do? This makes the narrow left ventricular outflow tract less narrow. It decreases this obstruction of the left ventricular outflow tract. It decreases this subaortic stenosis. So this gets wider, and when it gets wider, problem solved. That's no longer a patient, that's more akin to a healthy person. So you get less intensity of the murmur because there is less obstruction of the left ventricular outflow tract and everything is wide open. And when this is wide open, the blood flow will become more laminar and the murmur intensity will decrease. See, medicine makes so much sense once you understand what the flip you're talking about. Conversely, less blood meaning less dilation of this part because there is less blood volume in it. So this thick part and this thick part get closer to one another. More stenosis, more intensity. Oh, by the way, do you want to master cardiac pharmacology and learn about the antiarrhythmics, anti-hyperlipidemics, antihypertensives, diuretics, and digoxin? Download my cardiac pharmacology course at medicosisperfectionalis.com. Next, normal splitting of S2 heart sound. Normally we hear lub-dub, lub-dub, lub-dub. But to the experienced ear, there is lub and then d-dub. What's that? The aortic valve closes slightly before the pulmonic valve. And this is normal. This is physiology. This is called normal splitting of S2 heart sound. A2 is the aortic component of the second heart sound, and P2 is the pulmonic component of the second heart sound. The question of the century is, why did the aortic valve close before the pulmonic valve? Easy. Because closure is determined by pressure. Which side of the heart has higher pressure, the left ventricle or the right ventricle? Of course, the left ventricle has higher pressure. Since it has higher pressure, it slams that door shut sooner, before the pulmonic valve can close. Oh, so it's the difference in pressure that closes the valve. Since the difference in pressure here is humongous, the aortic valve will close before the pulmonic valve. All of this is the normal splitting. Okay, but in hypertrophic obstructive cardiomyopathy, what's gonna happen? I have severe left ventricular outflow tract obstruction. The aorta has to wait for the blood to reach it and go up here, and then it will close to prevent regurgitation. The question is, did the blood reach the aorta? Well, barely. Even if it did, it took longer to reach the aorta and come back. Why? Because of the obstruction. So if it takes longer, look at this, A2, it will be delayed past the normal P2. This P2 did not change. What changed is that the A2 happened later instead of sooner. Is this splitting? Yes. Is this normal? No, it's the exact opposite of normal. It's the antithesis of normal. So it's called paradoxical splitting. If you really want to understand HOCM, bring a piece of paper, a red pen and a blue pen, and let's doodle together. Here is the right side of your heart, right atrium upstairs and right ventricle downstairs. Here is my interventricular septum, and this is my left atrium and left ventricle. Amazing. Now, because this is HOCM, let's make the interventricular septum extra thick, just like that. Okie dokie, it's called hypertrophic for a reason, because we have hypertrophy. Don't forget that this septum will grab the mitral valve cusp closer to it, so I can get mitral regurgitation as well. The outflow tract is obstructed, as you can see here, leading to decreased cardiac output and the symptoms of low cardiac output. My heart will get angina, which can lead to chest pain, exercise intolerance, fatigue, and my brain suffers pre-syncope, syncope, dizziness, confusion, obtundedness, and sometimes sudden death from the ventricular arrhythmia, the palpitations. And because the cardiac output is low, where do you think blood is gonna go? It will accumulate before that thick left ventricle. It will go to the left atrium. It might reach my lungs, leading to pulmonary congestion, cough, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, maybe hemoptysis, maybe repeated chest infections, etc. Look at how thick that ventricle and that septum are. So I get S4 heart sound. Pressure overload, not volume overload. The right side could be affected as well, although to a lesser extent than the left side, so I get the problems with right-sided heart failure, which are jugular venous distension upstairs, lower limb edema downstairs, hepatomegaly or liver congestion in between. Upstairs, downstairs, in between. If you want to see more cardiology videos, please drop a heart emoji in the comment section. Let's review HOCM. It's bad at diastole, it is good at systole, but the left ventricular outflow tract is obstructed, so I get low cardiac output and the symptoms of low cardiac output. The thick septum might pull onto the mitral valve cusp, leading to mitral regurgitation. The thick septum and thick ventricle can lead to ventricular arrhythmias and palpitations. We might hear the murmur of mitral regurgitation. We might hear the harsh systolic crescendo-decrescendo murmur, most commonly at the left sternal border, but it can happen at the apex as well. Don't forget the paradoxical splitting of S2, and don't forget that we can hear S4. We can also develop the symptoms of right-sided heart failure and the symptoms of left-sided heart failure. What causes HOCM? It's usually a genetic disease, autosomal dominant pattern of inheritance, mutation of the genes that code for sarcomere proteins, including but not limited to beta-myosin heavy chain, myosin binding protein C, and there are many others. Sometimes HOCM could be caused by a lysosomal storage disease like Fabry's disease, a glycogen storage disease like Pompe's disease, and others, or mitochondrial diseases or Friedreich's ataxia. It can also happen due to cardiac amyloidosis. So amyloidosis of the heart can lead to what? It can lead to hypertrophic cardiomyopathy. It can also lead to restrictive cardiomyopathy, as we'll discuss in the next video. Then we have mitochondrial diseases, that's the M. What's the C? Well, the patient might suffer from CHF-like symptoms. Right-sided heart failure will give me something upstairs, something downstairs, something in between. Jugular venous distension, lower extremity edema, hepatic congestion. And left-sided heart failure will give me lung symptoms such as pulmonary congestion, pleural effusion, wet crackles, also known as rales, cough, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, hemoptysis, and repeated chest infections. What are the factors that decrease the left ventricular outflow tract obstruction and therefore improve the disease? And what are the factors that make the obstruction worse and worsen the disease? Remember when we said more blood, less murmur. If you want less murmur, give me more blood. Increase the preload. So if you give me more fluid, you will increase my blood volume. This is done by saline infusion. How about squatting? This increases my preload. How about hand grip? It increases afterload. Bradycardia. Well, the heart slows down a bit so we can fill it more with blood, and when we fill it more with blood, there is less obstruction. How about beta blockers, calcium channel blockers? I mean the non-dihydropyridine calcium channel blockers like verapamil. How about disopramide? This is an antiarrhythmic. It also leads to what? Bradycardia. All these three medications, whether verapamil, metoprolol, or disopramide, cause bradycardia, giving the heart enough time to fill. So you're increasing the preload and alleviating the obstruction. How about vasoconstrictors like alpha-1 agonists? This is the exact same effect as hand grip. You're raising the afterload, filling the heart with more blood. More blood equals less murmur. And that's why when we talk about the management of HOCM, what are the medications that we can give to these patients? You can give beta blockers, verapamil, disopramide, or phenylephrine. Very important to remember. How about the factors that make it worse? They are the factors that decrease the preload, such as volume depletion. High-dose diuretics for a long period of time can do it, and this is the opposite of ECF volume expansion. What's the opposite of squatting? Standing. What's the opposite of bradycardia? Tachycardia. What's the opposite of beta blockers? Beta agonists. And medications that boost cardiac contractility, because when you boost cardiac contractility, you will make my heart contract stronger, making the obstruction worse because the left ventricular outflow tract is getting narrower. How about Valsalva? Valsalva decreases preload, less blood, more murmur. Vasodilators such as nifedipine, nitrates. When you dilate my veins, the preload decreases because blood is stagnating in my veins, such as the veins of my ankle, and away from my heart, lowering the preload. Less blood, more murmur. And that's why if your patient has HOCM, do not give beta agonists, do not give digoxin, do not give dopamine, do not give nitrates, do not give nifedipine. See, medicine makes so much sense once you understand what the French toast you're talking about. You can learn about all of these medications by downloading my cardiac pharmacology course on my website, medicosisperfectionalis.com. Let's review everything on HOCM. By the way, it is the #1 most common cause of sudden cardiac death in young athletes. Causes are mostly genetic, don't forget amyloidosis. Signs and symptoms, CHF signs and symptoms, palpitations, crescendo decrescendo, harsh systolic murmur at the left sternal border, S4 gallop rhythm, paradoxical splitting of S2 heart sound, cardiomegaly, pulsus bispherians. What is bispherians? Look at bi. Oh, it has bi. So the pulse has like two waves like this. If you feel the carotid artery, look at this. Boom, boom, in the same pulse. The pulse is bifid, so to speak, bispherians. Next, the triple ripple. What the flip is that? It's a triple cardiac apex impulse. Feel the cardiac apex with your fingers and put your other hand on the patient's pulse on the radial artery. With each heartbeat, I feel not just one impulse here, but three. What? That's the triple ripple. Why 3? Atrial contraction, that's 1 because the poor atrium has to contract against a very thick left ventricle. Early rapid ejection and late slow ejection that has to overcome the left ventricular outflow tract obstruction. It does not have to be triple, by the way. It could simply be double. The patient might suffer from the symptoms of right-sided heart failure, upstairs, downstairs, and in the middle, and symptoms of left-side heart failure, which are lung problems. And don't forget the symptoms of low cardiac output, such as angina, pre-syncope, syncope, and even sudden cardiac death. How can I diagnose this? Clinically, by history, physical exam. Don't ever forget the family history. Then we do an EKG, we do an echo to find what? The left ventricle is so big, it's left ventricular hypertrophy. Chest x-ray might show cardiomegaly and it might show the signs of pulmonary congestion. A 24-hour Holter monitor might be beneficial as well as genetic studies for the gene mutations. How can we manage this patient? Avoid volume depletion at all costs because less blood equals more murmur in case of HOCM. The disease gets worse if the preload goes down. So stay hydrated and avoid strenuous exercise because strenuous exercise puts extra stress on the heart and this heart already has a problem. Strenuous exercise makes me sweat, which causes volume depletion. And many of these patients suffer from sudden cardiac death during strenuous exercise. Also avoid alcohol. Now, can someone explain why should this patient avoid alcohol? Please comment below. Which medication should I give? You should give beta blockers, but avoid beta agonists. You should give disopramide, but avoid digoxin. You should give phenylephrine, but avoid hydralazine. You should give verapamil, but avoid nifedipine. Pacemaker might help, implantable cardioverter defibrillator can help, and surgery. Do you want to learn about the cyanotic heart diseases and the acyanotic heart diseases? Do you want to know about the different types of shock, such as cardiogenic shock, hypovolemic shock, neurogenic shock, septic shock, etc.? If so, download my surgery high yields course at medicosisperfectionalis.com. To learn about angina, myocardial infarction, ischemic stroke, hemorrhagic stroke, many arrhythmias, ARDS, diabetic ketoacidosis, and much more, download my emergency medicine high yields course at medicosisperfectionalis.com. There are more than 300 premium videos available only to those who click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you'd like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.